All right, everyone. So this evening, what we're going to cover is epithelial tissue. We're going to start with tissues. And the opening slide here talks about epithelial tissue, connective tissue, muscle tissue, and nerve tissue. Of the four that we see, epithelium and connective has the most categories that fall under it. Muscle and nerve is fairly easy to understand. So the four primary types of tissues, remember, cells come together by a way of cell junctions, whether they be desmosomes, gap junctions, tight junctions, right? If you think about, let's say, the urinary bladder, right? It's holding urine. So we don't want urine spilling out of the bladder. So we need to make sure that those cells are held tightly together so that there's no leakage. So those are tight junctions that come together to form the urinary bladder. Okay, the same thing is true for the colon and the intestines, where the colon has bowel, it has feces. We don't want bacteria just escaping. So we need to make sure that the colon cells that come together are held together by tight junctions. Otherwise, they become leaky. And that creates a pathology called leaky gut syndrome. Okay, so cells come together. When cells come together, they make tissues. When tissues come together, they make organs. When organs come together, they make systems. And when systems come together, they make the organism. The four types are epithelium, connective, nervous, and muscle. Muscle and neural, as I said in the previous slide, are the easiest. I'm just going to lay down a little framework here with muscle and neural. Muscle tissue, there's only three types of muscle tissue. That's why it makes it kind of easy to learn. There's skeletal muscle, right? Right now we're doing bones, we're doing the skeleton. So muscles that attach to the skeleton, that move the skeleton, is called skeletal muscle. Then we have muscle that is involved with the heart. We call it cardiac muscle. That's the second type. And the third type is associated with our organs and blood vessels. We call it smooth muscle. So there's smooth muscle, cardiac muscle, and skeletal muscle. And of those three, only one of them is voluntary, meaning you have voluntary conscious control over it, and that would be the skeletal muscle, right? You could think about contracting your biceps brachii to move your forearm, and you can do that. That's voluntary. But you can't say to the smooth muscle around an artery to dilate on command or to constrict on command. You can't tell the uterus while you're having contractions to the uterus during labor, you can't say, and then stop it from contracting instantly, right? It's not voluntarily controlled. So those are three types of muscle tissue. When we cover neural tissue, the two types of cells that are associated with the nerve system or the neural system is going to be the neuron and the neuroglial cells or neuroglial cells. That's it, right? So it's the neuron, which is electrically excitable, and then the neuroglial cells, which are not. And the neuron is the main part that we'll focus on, and it has three main parts to it. It has dendrites, a cell body, and axons. So muscle and neural is the easiest of the two, and I'll go through them. It's epithelium and connective that has many categories that you're going to have to go over. So the tissues have different structures, they have different patterns. So if we're talking about structure and pattern, we're thinking form. That's anatomy, right? And then function is the physiology. So structure determines function. We're seeing that once again. When we study the tissues, we call it histology. We're going to look at epithelial tissue first. Now, one of the things that I want you to keep in mind when we talk about epithelial is to consider looking at let's say a classroom floor, right? Like the floor in a school is typically tiles. The flooring in a kitchen is usually tiles, right? So when you look at tiles, they're a bunch of, think of each tile as a cell, and it's a bunch of cells packed closely together. Think of graph paper, if you would, right? Like grid paper. It's all like tic-tac-toe, right? It's all vertical lines and horizontal lines. And if each of those little squares in graph paper is a cell, there's hundreds and hundreds and hundreds and hundreds of cells on that sheet of paper. And the lines that connect each square, that would be the matrix, the extracellular matrix. And in epithelium, there's lots of cells packed closely together with very little extracellular substance. Extracellular meaning outside of the cell. So let me just move ahead for a second so I can give you a visual to it. So if we look at any of these, if we look at, let's say here where it says stratified cuboidal, each of these is a cell, and they're packed closely together. And there's very, very little extracellular matrix, which means the space between it. Whether we're looking at this one to the left, stratified squamous, again, a bunch of cells packed closely together. If we look at transitional or pseudostratified, again, a bunch of cells packed closely together. We can see that there's a nucleus associated with each of these cells. That's classical for epithelium. Keep that in mind. A bunch of cells packed closely together. So epithelium is also going to line any surface that's going to come into contact with the external world. So when we think of a surface that comes into contact with the external world, one of the first places you should think of is the skin, right? The external layer of the skin is called the epidermis. That word, epi, means above. And dermis, you know, is skin. So there's a dermal layer, which is deeper. And then there's the epidermis, which is more superficial. So the epidermis is epithelium. It's going to cover the external surface of the body. Epithelium is also associated with lining cavities. A cavity is any type of tubular system. So if you think of the arteries and veins, those are tubes. If we think of the esophagus and the digestive tract, that's the tubes, like the esophagus and the stomach and the small intestine and large intestine. Those are tubes. When we think about the reproductive tract, anything that's a tract is a tube. The digestive tract, the respiratory tract, the reproductive tract, any tract is tubes. So any type of cavity or tubular system is going to be filled with epithelium tissue. And so are glands. Glands are specialized type of epithelium, whether we are talking about sweat gland, which is called a sudoriferous gland. If we're talking about an oil gland, which is a sebaceous gland, or whether you're talking about the breast gland, like the mammary gland for milk production, those are all epithelium. And there's a variety of functions of epithelium. Some protection, some absorption, filtration, excretion. One of the areas that we find epithelium, we said, is in a tubular system. When we think of tubules, you will be learning about the kidneys eventually. And the functional unit of the kidney is called a nephron. And the nephron is built with tubules. You will hear the term proximal, convoluted tubule, and distal convoluted tubule. So there's that word proximal and distal. So there's a proximal convoluted tubule and a distal convoluted tubule, part of the nephron. The nephron is the functional unit of the kidney, and this is where filtration, excretion, and secretion takes place, right? So there's the kidney is one of the perfect organs for epithelium that have many, many functions. Filtration, to filter the blood, to excrete, to get rid of things. When we talk about protection, we're thinking of the skin, right? We don't want something rubbing up against the skin that, like, let's say you had a scratch, you had an itch and you wanted to scratch your forearm. It has to have many, many layers of epithelium, because if it only had one layer, once you scratched yourself, your nails would peel off that top layer and you would be bleeding, wouldn't you? So epithelium can come in different layers, where it could be one cell layer thick, or it could be many, many, many cell layers thick. If it's an area that is exposed to a part of the body where there could be lots of friction, lots of bacteria invading the body, prone to chemical damage like your skin, we would want multiple layers of protection there. Which is why when we look at the skin, and we will today, we will see that the epidermis isn't just one cell layer thick. It is many, many cell layers thick. Epithelium also has cilia. Cilia are these little hair-like filaments, these protein filaments, and they are located in the respiratory tract, especially in the trachea, and they beat rhythmically from inferior to superior to sweep up dust. That's the beauty of the cilia. They're designed to prevent dust particles and debris from breathing in and going down into the lungs, into the alveoli. So we have these goblet cells that produce mucus, and that mucus sticks to the cilia. And as foreign particles are inhaled in, it sticks to the sticky substance located on the cilia, and it gets trapped there. So it doesn't make it down deeper into the lungs. And when that happens, you just do this, right? And it gets it up and out. Absorption, there's absorptive epithelium, which is in the GI tract. GI is gastrointestinal tract. That's the stomach and the intestines. Think of that as the sponge, absorption. It's going to absorb vital nutrients and pull it into that system. So we mentioned cilia. These are these long, slender-like extensions. We saw them when we covered the cell, and they help to move the cell, and they can move things along the cell's surface as well. But then there's something smaller than cilia called microvilli. These microvilli are located in different parts of the body that are important to help increase absorption and secretion. Microvilli. So when we look at epithelium and we look at it under a microscope, we have to be able to give it a name. And we're either going to call it a simple or stratified. If we look at the cells and they're only one layer thick, we call it simple. If we look at it from the side and we see multiple layers, we call it stratified. So again, if we look here from the side, we see one cell layer here. We see one cell layer. We see one. So all of these have the word simple. But when we look down below and we see multiple layers and more than one layer, we use the word stratified. So let's go back. If it's one cell layer thick, it's simple. If it's more than one cell layer, it's stratified. So the first question we ask ourselves is, how many layers do we see closest to the top, right? To the apical surface. How many layers do we see of these cells? Or we find a lumen. When I say lumen, I'm talking about this. Like if we're looking at a hole, the lumen is the hole or the space of the tube. That would be a lumen. Like if we look at an artery, blood is flowing through the lumen. If we look at the trachea, air travels through the center of the trachea. If we're talking about the intestines, that's a lumen. We have food traveling through the center of that lumen, that hole in the center of it, in the center of the tube, right? If you look at a garden hose, the lumen is where water comes out of, right? That would be the lumen. So we would look at how many layers of cells we see closest to the inside of the lumen. If we saw one layer thick, it's simple. If we see more, it's stratified. But then the second question is, what's the shape of those cells? Do they look like squares? Then we will call them cuboidal. Do they look like tall columns, like buildings? We'd call them columnar. Or do they look like these flat, irregular cells? We call them squamous. So cubes, cuboidal, buildings or rectangles, we call them columnar. And if they're flat, irregular, we call them squamous. So now let's look here, top center, one cell layer thick. They look like squares, so it's simple, cuboidal. If we look down below it, it's not one, but it's two, so it's more than one cell layer thick, and they're cube-shaped, so now it's stratified, cuboidal. When we look up here, we see these flat, irregular shaped cells, so it's one cell layer, simple, squamous. If we go down below, again, this is the apical surface, the top, and we see 1, 2, 3, maybe 4 layers of these flat, irregular cells, so it's stratified, squamous. Over here, these are one cell layer thick. We see the nuclei are all aligned, they're all in the center, simple, columnar. Now, what's unique about columnar is that we never really see a stratified columnar. We see what's called pseudo-stratified columnar. And the word pseudo means false. So it may look like there's many layers of these tall columns, but it's not. And the reason why it looks like there's many layers is if we look at simple columnar, the nuclei are just at one level, but when we look down below, we see a nucleus here, and here. It looks like it's multi-level, so we would assume that it's stratified, when in fact it's still one layer thick. So we call it pseudo-stratified columnar. That's what's unique about the columnar cells. Transitional, it's when we see cells that are multiple shapes. It doesn't just fit cuboidal, it's not strict squamous, it's not strict columnar. You see a variety of shapes. And the way to understand transitional is think of a deflated balloon. You haven't blown it up yet, right? So you have this deflated balloon and you draw a circle on it, a very small circle with a marker. Then you blow up the balloon. What happens to that small circle? It changes its shape. It becomes bigger and it spreads out and opens up. So transitional cells are found in parts of the body where you have organs that can change their shape and size. So any part that deals with the kidneys, like the urinary bladder, the ureters, the uterus, the reproductive tract for the female, the uterus can certainly, it starts off as the shape of an inverted pear, and then it can get as large as a basketball, right? So as that starts to stretch with pregnancy, you can imagine the shape of the cells will transition. So that's where transitional is found. So again, we have simple epithelium and stratified. Simple is one cell layer thick, stratified is multiple. Squamous, cuboidal, and columnar refer to the shape of the cells. Now there's different functions for them. Squamous is for protection, secretion, and diffusion. Remember, diffusion is when you have something that can pass through a membrane. So we have oxygen and carbon dioxide that can pass through a membrane. We have sodium and potassium that can diffuse across a membrane. Cuboidal cells, you heard me talk about the nephron and the kidney tubules, where you have a lot of secretion and absorption taking place. There's cuboidal cells there. Columnar is found in the digestive tract, and you can find it in the respiratory tract, especially in the upper respiratory tract. So pseudostratified, I mentioned that it's like simple columnar, right? But it has this false appearance of being stratified. Why? Because the nuclei are at different levels. So it gives it this false appearance that perhaps it's stratified, but it's false. So it's pseudo-stratified. And wherever we have pseudo-stratified epithelium, you're going to have cilia with it. So we would call it pseudo-stratified ciliated epithelium, or pseudo-stratified ciliated columnar epithelium. Transitional, we said it's in the urinary system, the urinary bladder, the uterus, urethra, ureters, anything like the balloon that's going to expand and contract. So the cells will change shape. So again, for epithelium, these are cells packed closely together. Simple squamous, simple cuboidal, simple columnar, or it's multiple layers, stratified squamous, stratified cuboidal, stratified columnar. The two that fall under stratified is the pseudo-stratified columnar. It's not really stratified, it looks it, and we said that there's cilia that are often associated with it. We find it in the respiratory and digestive tract. Transitional epithelium is the uterus, the ureters, the urethra, anything in the urinary tract. So now we have functions. So what are we going to use simple squamous epithelium for? Well, we said diffusion, protection, filtration, secretion. So we're going to have simple squamous epithelium that are used primarily for those functions. Diffusion, again, is crossing through the membrane. Simple cuboidal. When we hear cuboidal and simple cuboidal, I'm thinking the kidney tubules. Absorption, secretion, and protection. When we talk about stratified squamous, not simple, stratified, right? Simple squamous, it's a lot easier for something to diffuse through one cell layer thick, but when it's stratified squamous, I think the epidermis. I'm thinking the top layer of the skin, many, many layers of squamous cells to protect the body. When we have pseudo-stratified columnar, pseudo-stratified, epithelium that functions in the movement of secretions like mucus. Okay, well, this may sound a little bit new, but what you heard me say before was that where you have columnar cells or pseudo-stratified columnar, I said there's always cilia. And what's associated with those ciliated columnar cells are goblet cells. And I said goblet cells produce mucus. That mucus is secreted or excreted, and it sticks to the surface of the cilia. All right, so now it kind of makes a little bit of sense when we talked about the trachea and having dust particles stick to it, and then you go, right, like that. Transitional, we said that if an organ can become distended or it can relax, any organ that can change its volume, how much it's holding, like the urinary bladder. So that's a little bit of epithelium. Now, what's connective tissue about? Remember I said epithelium is a bunch of cells held closely together with very little matrix, very little extracellular matrix. Remember the tiles or the grid or the sheet of paper that had all the bunch of graph paper that has all the little cells closely packed together. Now with connective, it's the opposite. Connective, we have cells here and there with lots of extracellular matrix. That's the difference, a big difference. Instead of having cells closely packed together, they're here and there. Like if you were to look at a blood smear under a microscope, you would see like a red blood cell here, maybe another red blood cell and a white blood cell. You'd see cells scattered, but not on top of each other where you don't see any extracellular matrix. In fact, In fact, most of the blood is matrix. When you get blood pulled out of you and it goes through a centrifuge and it gets spun and it separates, only 45% of that blood is going to be formed elements like red blood cells and white blood cells. The other 55% is matrix. So that's a classical definition of connective tissue. Some cells, lots of matrix. Epithelium, lots of cells, little matrix. So connective tissue is the most abundant and variable type of tissue in the body. And there's a bunch of different functions of connective tissue. They do connect organs to each other. They even connect the epithelium to the rest of the body. They give support and protection to us. And not just physical protection, like bones being connective tissue, ligaments being connective tissue, tendons being connective tissue, but we also talk about the immune system, the white blood cells, antibodies. That's part of connective tissue. It's just not solid connective tissue. It's considered liquid connective tissue. So blood is liquid connective tissue. So when we talk about connective tissue, we're going to break it up into different categories. And we'll show you those categories in a second. Connective tissue is also involved with the storage of energy and heat production. Our fat cells, that's what adipose is. Adipose is heat production, or fat cells that act as an insulator, keeps us warm. And then movement and transport of material. We need blood in our blood vessels in order to do that. So let's look at some of the different categories of connective tissue. So we have connective tissue proper, and under connective tissue proper, look, we have loose connective tissue and we have dense connective tissue. So let's go back. We have connective tissue proper, there's loose connective tissue, and then there's dense connective tissue. And you see under each, there's a few subcategories. So under loose connective tissue, there's areolar, adipose, and reticular. Under dense, there's regular dense, irregular dense, and elastic. Then we have fluid connective tissue. Before you heard me say blood is fluid connective tissue. It's not solid like bone. So there's fluid connective tissue. We have blood and lymph that fall under that. Then we have supportive connective tissue. There's cartilage. And under cartilage, there's hyaline cartilage, elastic cartilage, and fibrocartilage. Then we'll talk about bone and some of the different characteristics to bone, especially compact bone. Okay? All right, so let's go back to connective tissue. Just wanted to give you where I'm going to be going with this. So under loose connective tissue, there's areolar, adipose, and reticular. Areolar is that space that separates your skin from the muscle that's deep to it. So areolar is going to provide padding, and it separates your skin from the deeper tissues. And it's made up of elastic and collagen fibers. If you look at the word elastin, it sounds like it's elastic, like a rubber band has the ability of stretching but recoiling back. That's what elasticity is. And then collagen fibers come from a protein called collagen. And collagen gives things more of their strength and stability. So there's collagen in bone, there's collagen in muscles, there's collagen in skin, there's collagen in tendons. Okay. Adipose is considered loose connective tissue. These are fat cells. Sometimes they're referred to as adipocytes, but they're fat cells, and they tend to look a little bit like squamous cells, except when you look at a squamous cells have a nuclei right in the center. Adipose has a nucleus that's to the periphery. Hard to see it. Reticular is also loose connective tissue. This provides the framework for support. Looks like a meshwork. So that was loose connective tissue. Now dense connective tissue, if you look at dense regular compared to dense irregular, Dense regular is when you have these collagen fibers that are packed closely together in these parallel forms. So tendons and ligaments, you're going to see a bunch of collagen fibers packed closely together in harmony. But dense irregular is where we're going to see collagen fibers in different directions. They're not all linear in the same direction. They could be even perpendicular to each other. Okay? So muscles and tendons, when you look at muscles, you're going to see fibers in the same direction. But dense irregular, we're going to see fibers in a multitude of directions. Elastic connective tissue, there's that word elastic. Ligaments need to have a degree of elasticity. Now, ligaments are not tendons. There's a difference between tendons and ligaments. Ligaments are this anatomical soft tissue structure that goes from one bone and it attaches to another bone. Okay, so if I'm looking at my elbow and I have a ligament on the inside of my elbow, that could be my ulnar collateral ligament. And on this side, on the radial side where my thumb is, that could be the radial collateral ligament. So those collaterals need to be, they're going from one bone to another bone, humerus to ulnar, humerus to radius. We have ligaments that attach to each vertebral segment from one vertebra to another, bone to bone. Those are ligaments. But there's a difference between ligaments of the spine compared to, let's say, ligaments of the knee. If we look at the spine, and we'll look at the vertebra in a few minutes, and we'll talk about the major parts of a vertebra, but they all interlock. One vertebrae, another one, and the way it's designed, one bone on top of another, they kind of interlock, so they're pretty stable, but yet the spine is pretty flexible. So we need to make sure that the ligaments can assist in that degree of flexibility. So those ligaments need to have a lot of elastic tissue associated with it. But if you look at the knee is the largest joint of the body, and it's very unstable. So when we have ligaments going from the femur to the tibia, since it's very unstable, we want to make sure that those ligaments have more support. So they may have more collagen than they do elastin. Okay, structure, function. Okay, so that was loose connective tissue, dense connective tissue. And we have fluid connective tissue. That's blood. And most people don't think that blood is connective tissue, but by definition, it's cells scattered around here and there with lots of matrix, extracellular matrix. It's just that the extracellular matrix of blood is called plasma. That's called plasma. So the red blood cells are erythrocytes. They're going to carry blood gases like oxygen, carbon dioxide, and nitric oxide. White blood cells, these are called leukocytes. And white blood cells can be granular cytes or agranular cytes. Granular cytes have granules in the cytoplasm. That would be your basophils, your eosinophils, and your neutrophils. And your agranular cytes, those are called monocytes and lymphocytes. So if your lymphocyte count is really, really high, then you'd say you have a virus of some sort. If your neutrophils are really high, we'll say you have a bacterial infection. So understanding a little bit about white blood cells and leukocytes are important. We see that they fight infection. So leukocytes are white blood cells. You have granular cytes, which are basophils, eosinophils, and neutrophils. And then you have agranular cytes. Whenever you put the letter A in front of it, it means without granules. So we have an agranular cyte, and those are your lymphocytes and monocytes. Monocytes become macrophages. Platelets help us clot. So if you get a cut and then you're bleeding and then it stops, thank goodness, due to platelets. There's certain drugs and medications out there that can inhibit platelets, right? We know that people take aspirin or baby aspirin to thin out the blood, and these are the people that bruise very easily. Warfarin and Coumadin, these are things that block platelets from working. Lymph, this is interstitial fluid. This is the stuff that we find between the cells, not within a cell, but between the cells of the human body. That's called lymph. We have lymph nodes like the tonsils. The tonsils are lymph nodes. We have lymph nodes in front of the ear, behind the ear, in front of the sternocleidomastoid, behind the sternocleidomastoid, in the upper arm, around the breast tissue, in the groin, in the axilla. There's lymph nodes everywhere. Okay, so we did connective tissue proper. We did loose and dense connective tissue. We did fluid connective tissue. Now let's look at supporting. For supporting, we're going to do cartilage and then we'll do bone. So cartilage is avascular, meaning without blood supply. So when cartilage gets damaged, it takes a long time for cartilage to heal. The three types of cartilage are hyaline cartilage, elastic cartilage, and fibrocartilage. Fibrocartilage is the strongest. Your intervertebral discs are considered fibrocartilage. The IVDs, the discs between each vertebra. Hyaline cartilage is the type of cartilage you find between your movable bones, like the glenohumeral joint, the elbow joint, the wrist, the fingers. Anything that is voluntarily movable and freely movable is going to have hyaline cartilage. So that's the most common type of cartilage that we see. It's going to cover where bones come together and form joints. Elastic is going to allow for tissue flexibility. There's elastic cartilage in the ear, there's elastic cartilage in the nose, there's elastic cartilage in the lungs, there's elastic cartilage in the eustachian tube in the inner ear. So that's cartilage, avascular. Bone also falls under supportive. There is a key structure called an osteon, and an osteon is found where we have compact bone. So there's compact bone and spongy bone. Spongy is as it sounds. It looks like a sponge, very porous. Compact sounds like it's compact. And when I show you a picture of it, you will see. The other terms to be familiar with, osteoblasts and osteoclasts. Osteoblasts and osteoclasts are similar. They work together to remodel bone, but they do it in opposite ways, right? The osteoblast is building up bone, whereas the osteoclast is breaking down the bone. Again, osteoblasts build up the bone by making the matrix, and osteoclast breaks down the bone. They dissolve the matrix. So when you have osteoclasts working overtime and it's breaking down bone at a faster rate than it can actually build up, that's what osteoporosis is, or osteopenia, the breaking down of bone. Osteoblasts make the matrix. Think of it as it's pushing out calcium and calcium phosphate and hydroxyapatite. It's making all the matrix. But as it's pushing out the cement, if you would, eventually cement dries. And when it dries, it hardens. And when it hardens, the osteoblast gets trapped in its matrix and it can't get out. The osteoblast now becomes an osteocyte. Okay, the osteoblast becomes an osteocyte. I'll show you what some of these other structures are because they're kind of important. So I think it's just better to show it in a picture. So this is, if you look at a bone up here on the top left here, this looks like it's the femur. This looks like the head of the femur. Up here it's spongy bone. Down here it's spongy bone. And over here on the periphery here and here, this is compact bone. And then in the inside, again, it's spongy. So if we take this section out, we blow it up, the outer portion is here. See, this is all compact in the periphery. And in the compact part, we see these osteons. An osteon, if you look at it, it looks like someone chopped down a tree and then you're looking bird's eye view, looking down and in on it. These are osteons. So this is an osteon, 1, 2, 3, 4, 5, 6. Looks like 8 different osteons that we can see here. The rings going around them, those are called concentric lamellae. Concentric lamellae. If I go back here, we see that we have concentric lamellae, circumferential lamellae, interstitial lamellae. Lamellae are just these rings. Concentric makes the full ring. The circumferential goes around the entire outer perimeter. And what's left in between the cells, between this osteon and this osteon, or between this one and this one, this is where we see the interstitial lamellae. And what's interstitial lamellae? All they are really remnants of older osteons that didn't make a full concentric ring because the osteoclasts were breaking them down. Osteoclasts break down bone, osteoblasts build up bone. Notice that blood is very vascular. You see the blood vessels in between? They go right through the central canal, aka the Haversian canal. There's artery, there's nerve, there's vein, there's lymph. You could see it. It goes through the center of each and every osteon. So blood, bone is vascular. If you break a bone, you will bleed internally, and it forms a tumor of blood called a hematoma. So compact bone is here. In the inside is spongy bone. It looks spongy. Compact, spongy. When we look at a model of a bone, again, same exact structures. Also want to point out that the outside of the bone, the very, very outer portion, is called the periosteum, whereas the inner part of the bone is called an endosteum. You see the word oste, like osteology is bone, en for in, peri is outer. So there's a periosteum and an endosteum. Endosteum is on the inside, periosteum is on the outside. So which layer will muscles and tendons and ligaments attach to? Well, ligaments attach to the outer part of the bone. So they have to attach to the periosteum. Okay. So the outer part is the periosteum. Inner part is the endosteum. This is all spongy bone. We see number 1, trabecula or spongy bone. Each of these is an osteon. All of these. So if you look, let's see, here's 1, 2, 3, 4, 5, 6. All of these circles, each one of these is going to be an osteon. So number 6, right here, this is just one full osteon. And it's got all these concentric rings. Okay? Okay, we talked about muscle tissue. We said there's skeletal, cardiac, and smooth earlier on. Skeletal is the only one that's voluntary. Cardiac and smooth is involuntary. Skeletal muscle looks striated under a microscope. It looks like it has these light and dark filaments. But so does cardiac. So they're both considered striated. When it doesn't have striations, it has a smooth appearance. So under a microscope, when we look at skeletal muscle here, we see that we have striations. It's like light, dark, light, dark, light, dark, these light and dark bands. But skeletal muscle, like for the triceps or biceps, that skeletal muscle, it's voluntary. You have conscious control of it. What else is striated, again, is cardiac. This is also striation, light and dark bands. But look at the difference between skeletal and cardiac. When you look at cardiac, it's very branched. It's highly branched. So there's lots of branches that happen. It splits off. And the other thing that we see are these intercalated discs. And all intercalated discs is the junction or union where this heart cell and this heart cell unite, where they come together. That's all it is. Where the two cells come together, it's called an intercalated disc. And the type of junction that's in between here is called a gap junction. Gap junctions are used wherever we need fast, rapid forms of communication between one cell and another cell. And since the heart cell needs to rapidly communicate so the entire heart can contract in sync and in harmony, you need those gap junctions for fast, rapid forms of communication. Now notice these are striated. This one is smooth. That's your smooth muscle. They're spindle shaped. They're spindle shaped. You can see here, very spindle. This is going to be involuntary, and you're going to find it in your digestive organs. Okay, things that are involuntary that you can't control, just like your blood vessels and the uterus and the colon and the small intestine. Now, what we have left, the fourth type of tissue, is the neuron. We call it the neural system or nervous system. The two cells that fall under the nervous system is going to be the neuron, which is what we're looking at here, and the other type are called neuroglial cells or neuroglial cells, which means nerve glue. Of the two, the only one that's electrically excitable is this one here called the neuron. The neuron has three main parts. We have the dendrites, which look like the branches of a tree, and that's what dendrites mean. In Greek, it comes from the Greek word dendra, which means tree. So we have dendrites, which bring in information into the cell body. And the cell body is sometimes called the soma. And then the soma, or the cell body, sends that information away, this way, through an axon. So the axon is this entire thing. So information comes in through the dendrites. It gets processed here in the cell body. That's the nucleus. Then the neurological output goes away, A in axon, A for away, all the way down to the very end, called the axon terminal. And what protects the axon is fat and cholesterol. It's called the myelin sheath. This is an insulator that protects the axon. It is cholesterol and fat, and it's designed to speed up. It speeds up the action potential, so it can go from here all the way to the end where the axon terminal is super fast. And what we have at the end of the axon terminal, it stores proteins at the very end in these end bulbs. These end bulbs, they're like light bulbs. They're end bulbs, and they store these neurotransmitters. And the neurotransmitter can be released on command. It can be released through exocytosis. And maybe it's an excitatory neurotransmitter. Maybe it's an inhibitory neurotransmitter, right? Neurotransmitters are now using think of it as like a hormone, right? It's not an electrical impulse, it's a chemical one. And maybe it's going to release serotonin, maybe GABA, maybe acetylcholine. These are all neurotransmitters. They will release a chemical message to tell the body to turn on or to turn off. It could be an excitatory impulse or an inhibitory impulse. Maybe it's going to tell your brain to become stimulated, or it's going to tell your brain to shut down. So in the morning when we get up, we need glutamate, which is an excitatory neurotransmitter. But by the time 8, 9, 10 o'clock comes, like, late at night, that excitatory neurotransmitter can turn to GABA, which is an inhibitory neurotransmitter. It turns off the brain. It keeps you calm at night so you can sleep. Now, we know that there are people that go to bed and their brains are very active. They can't go to sleep. Their brains just won't shut down. That means they're glutamate dominant or they're GABA deficient. And then we know that there are people that when they wake up in the morning and the alarm goes off, they're constantly hitting the snooze button. They just want to go back to bed. Just give me 10 more minutes, please. Just 15 more minutes of sleep, right? Those people are glutamate deficient or GABA dominant. So you want to be able to get up in the morning and be bright-eyed, bounce right out of bed. And then at nighttime, you want to calm down. It's like the difference between the flower opening up in the morning and then at nighttime, the flower closes up. Okay, so now that brings an end to the tissues. And now the first system that we would get into would be the integumentary system, especially the skin. Now, the skin is the perfect organ to cover next because it has all four types of tissues that we just talked about. There's epithelial tissue, connective tissue, nerve tissue, and muscle tissue, all here in the skin. So up here, the top layer, that's the epidermis. Especially this top layer, it's many, many layers of stratified squamous cells. Okay, so that's part of the epidermis. Then below that is the dermis. Now the epidermis, I'll show you in a second, has 5 microscopic layers. And there's a little silly mnemonic to help you remember those. The dermis only has 2 main layers, the papillary and reticular. Papillary is more superficial, and reticular is a little bit deeper. And look at all these neat structures that we have in here. Whoa, we have some glands. We have some muscle. We have blood vessels. We have nerve, right? So you've got some cells with lots of matrix in here. You got fat at the bottom. This is adipose. All this yellow, this is fat. So you got connective tissue, connective tissue, connective tissue, muscle tissue, nerve tissue. So we have everything here, right? This is the erector pili muscle. The erector pili attaches to the hair follicle. And when this contracts, it pulls the hair on end, and that's what gives you goosebumps. Then over here, we've got the sebaceous gland. That's epithelium. Sebaceous gland, that's oil. That's an oil gland. So it pushes oil up this hair shaft and creates this antibacterial watertight seal right around the hair. So you don't get bacteria invading. Once you get bacteria that find its way in, then you get acne. That's what acne is. It's an infected sebaceous gland. You got this lamellated corpuscle or Pacinian corpuscle. That's for deep, deep pressure. This is a sudiferous gland, right? Sudiferous, which is your sweat gland. That's your sweat pore. Then down here at the bottom, you got your subcutaneous or your hypodermis. So you got your epidermis on top, dermis in the middle, and you got your hypodermis down here at the bottom. We'll take a look at the layers of the epidermis. Again, this is just another model of the skin. So now let's see if we can figure this out. Let's see, what type of tissue? We're looking at a network of specialized cells that monitor the internal and external environment. Well, okay, if it's monitoring the inside and outside, and it's going to initiate a command, well, that's your Houston control, right? That's your neural tissue. What is classified by the number of cells and the shape? Well, that's epithelium. We got that, right? Simple squamous, stratified squamous, simple cuboidal, stratified cuboidal. All right, skeletal, cardiac, and smooth. We know that's easy, right? That's muscle tissue. We know that muscle tissue is widely distributed through the body and allows for movement of the skeleton. There's going to be over 600 muscles in the body. There's 206 bones, over 600 muscles. Which is the most diverse, abundant, and widely distributed type of tissue? Well, it's not epithelium, it's connective. Which one is going to line the surface layer of the body? It's going to line cavities, hollow organs, and it makes up your glands like your mammary gland and sebaceous gland. And that's going to be epithelium. And which one's composed of the neuron and the neuroglial cells? Again, that's neural tissue. We went over that there was fluid connective tissue, supporting connective tissue, and then we said there was connective tissue proper. So the first one we covered was this, connective tissue proper. We said there was areolar connective tissue, adipose, and reticular. Right? Adipose was fat, reticular makes up the framework, areolar separates your skin from the underlying muscle. Then there's dense regular versus dense irregular. Dense regular was when the collagen fibers were closely packed together. Dense irregular was when they're moving in different directions. So this would be like, dense irregular would be like your dermis of the skin. And then dense regular would be like your tendons. Then you have dense elastic for that flexibility. Supporting, compact bone, remember the osteons, the lamellae, concentric lamellae, the periosteum, and then we talked about 3 types of cartilage, hyaline cartilage, elastic, and fibro. Fibro is the strongest. That's your intervertebral discs or even your pubic symphysis, which is where your pubic bones come together. Elastic is for flexibility. And hyaline is where your diarthrodial joints, which are your freely movable joints. It's also known as articular cartilage because it's where 2 bones articulate. And then there's fluid connective tissue like blood and lymph. Okay, so just different ways to help you organize these things. Again, other ways of trying to categorize them in your head. If we looked at simple squamous, stratified squamous, simple columnar, and pseudostratified columnar, we know that those are different types of epithelial tissue. Connective tissue would be compact bone, all the different cartilage, areolar, adipose, that's all connective. The neuron, that's nervous tissue. Whether it was cardiac, smooth, or skeletal, that's muscle. Where do we find elastic cartilage? Things that have more flexibility. The external ear, the nose, the epiglottis, which is in the back of the throat. Right? The epiglottis is really important because when you swallow food, it goes down your esophagus. It doesn't go down your windpipe. And when that happens, and it's happened to everyone at least once, where you laugh or water goes down the wrong pipe, that's because the epiglottis didn't shut down the windpipe. Okay, so epiglottis is elastic cartilage that folds down and closes off the windpipe, so your food gets diverted down the esophagus, the right pipe. Hyaline cartilage, this is found at the end of the bones. That's also known as articular cartilage. The nasal septum, that's hyaline cartilage. The rings that go around your trachea, your windpipe, there's cartilage there. That's called hyaline cartilage. And then there's the thyroid cartilage of the larynx. So the thyroid cartilage, also known as sometimes the Adam's apple, that's hyaline cartilage. And then the fibrocartilage, that's the pubic symphysis where your pubic bones come together. That's the vertical disc that goes up and down. The IVD, which is the intervertebral disc, that's fibrocartilage. And then there's the meniscus. There's the medial and lateral meniscus of the knee. That is very strong. That's fibrocartilage. Then there's another, you can keep breaking this down, but this is just very, very linear as to what we covered before. So when we looked at connective tissue, we said there was connective tissue proper, supporting, and fluid. Fluid is blood. Supporting is cartilage and bone. When we did bone, we talked about compact versus spongy. Talked about cartilage, it was hyaline, elastic, and fibrocartilage. And then under connective tissue proper was loose and dense. Dense was regular, irregular, and elastic. Loose is areolar, adipose, and reticular. Now let's look at bones themselves, just to help make sure that you guys can review some of this. So when we look at this looks like it's the left foot, that's the great toe. This is the femur, this is the patella, this is the tibia, and this is the fibula. So right here, well, the patella is this, that's the kneecap. The medial malleolus, that's this right here, that's the medial malleolus. On the other side is the lateral malleolus. So the medial malleolus is the inside of the tibia, the distal end of the tibia, whereas the lateral malleolus is the lateral distal end of the fibula. Up here is the head of the fibula. So this would have to be the tibial tubercle or tibial tuberosity. Now, why is that important? That's where all of your quadricep muscles are going to attach. All the large muscles of the femur or the thigh, they cross over. They cross over the patella and they attach to the tibial tuberosity. There's a clinical condition called Osgood-Schlatter's that's usually seen in young teenagers from playing, let's say, soccer, hockey, any type of sport that overuses the quadriceps will eventually create strong pulling contractions on the tibial tuberosity, and there's a bump that becomes quite prominent here. It's called Osgood-Schlatter's disease. It sounds very, very serious. It is not. It's just an overuse of the quads when the bones are still forming and the tibial tuberosity becomes quite pronounced. Okay, we're still looking at the tibia and fibula. On the left-hand side, it's the anterior, and on this side, it's the posterior. So tibial tuberosity is going to be up here in the front. The shaft of the fibula, well, this is the shaft here, or the shaft would be here. Lateral malleolus, well, that's the distal end of the fibula, which is here and here. Head of the fibula, that's way up at the top. Just remember, tibia is the thicker bone. Fibula, just remember you tell a small fib. So the fibula is the smaller leg bone. So that means that that would have to be right here. What's below your head is your neck. So that's the neck of the fibula. Well, let's see. Here's the scapula. Down here is the lumbar vertebrae. Here's the sacrum. Here's your coccyx. There's your cervical vertebrae, right? You got cervical, 7 cervical vertebrae, C1 to C7. Then you have 12 thoracic, T1 to T12. Then you have 5 lumbar, L1 to L5. Scapula, well, these are the 12 ribs. Notice each of the ribs will articulate with its corresponding thoracic vertebrae. So there's 12 thoracic vertebrae, and there's also 12 ribs on each side. The last 2 ribs are called floating ribs because there's no cartilage that attaches there. First rib would be T1, second rib T2, last rib T12. And that's why when someone has a scoliosis, right, and the spine starts to curve, we can use the ribs to also determine if there's rotation there or curvature, because if the spine moves, the ribs have to move with it. You will see that the ribs attach to the vertebral bodies and to the transverse processes of the vertebrae. A lot of bony landmarks. So up here is your frontal lobe. Then you have your maxilla, the upper jaw, mandible, lower jaw. Here is the nasal septum in the middle. The bottom is the vomer. So now we're left with right here, in here, this is your ethmoid. That is your ethmoid bone. Ethmoid. Zygomatic, that's your zygomatic arch right here. Here's the orbit of the eye. We have turbinates here. Turbinates. Turbinates, also concha. When you breathe in air, it's like a turbine. It spins the air as you breathe it in, and it warms it up and pulls debris and lets it stick to the membranes of the nose. Make sure you review the anatomy, the bony anatomy of the hand. So in a hand, you have 8 carpals. In the foot, you have 7 tarsals. So there's 8 carpal bones. And you always want to learn them in anatomical position from lateral to medial. There are 4 bones. 1, 2, 3, 4. Hold on, let me see if I can get this. Sorry, let's do it here. 1, 2, 3, 4. Then we have 5, 6, 7, 8. So there's 8 bones. 4 in the proximal row. 1, 2, 3, 4. And then we have 4 in the distal row. 1, 2, 3, 4. So let's see what they are. So this one is the scaphoid. This one is the lunate. This is the triquetrum. This one is the pisiform. So there's a little silly mnemonic, and it's called "Some lovers try positions that they can't handle." Some lovers try positions that they can't handle. So some would be for scaphoid, lovers would be lunate, triquetrum. Some lovers try positions that would be pisiform. That they can't handle, then you would say this is the trapezium, trapezoid, capitate, and then this is the hamate. Right? So it's a little silly mnemonic. It's been around forever and ever and ever. You just divide the bones into 2 rows, a proximal row and a distal row. There's 4 in each. You always start from the proximal row on the lateral side. The lateral would be the thumb side because the thumb radiates out. So it's on the radial side. This is the radius. This is the thumb. The thumb radiates out. So some lovers try positions, scaphoid, lunate, triquetrum, pisiform, that they can't handle, trapezium, trapezoid, capitate for capital, like the largest, and then here's the hook of the hamate. Okay, hopefully that helps you remember it. Okay, then we have in the nose, we have the nasal septum in the center. The bottom part right here is called a vomer, and then the upper half is called the perpendicular plate. So they're almost the same thing, right? Together it makes up the nasal septum. So the vomer is on the bottom portion, perpendicular plate is up here. The concha or the turbinates, this is the inferior concha, and then up here would be the superior one. So the inferior nasal concha, as you breathe in air, it's going to spin and centrifuge the air. So if it's cold out, it warms it up. And if there's any debris, it's going to get the dust particles to stick to the mucous membranes of the nose. So that's the purpose of the concha, just like the concha of a shell, right? It looks like a spiral or a turbinate. When you look at the cervical vertebrae, here's the base of the occiput. Here's the back of the skull. This is your mastoid process. This is your C1 vertebrae. This is C2. C1 is the atlas, holds up the world, right? The Greek god holds up the world. Then you have C2 is axis. Then you have C3, C4, C5, C6, C7, and then T1. Usually one of these 2 spinous processes are very prominent, so they call it the vertebral promenades. Usually it's C7. Around 70% of the time, C7 is the more prominent bump at the back of your neck. 30% of the time, it's about T1. Notice the spinous processes are bifid, like a fin. It splits or forks. Those are only bifid spinuses. Processes are only seen in the cervical vertebrae. Okay, and then the transverse processes go outward on the sides. Transverse process. spinous process. C1 does not have a spinous process. It has a posterior arch and it has an anterior arch, but there is no spinous process. In the hand, besides the carpals, what comes after the carpals are metacarpals. What comes after the metacarpals are phalanges. And the phalanges on digits 2, 3, 4, and 5, this is the thumb. So the thumb is digit 1, digit 2, 3, 4, 5. So digits 2, 3, 4, and 5 have a proximal, a middle, and a distal phalange. So the phalanges are the ends, but there's a proximal, middle, and distal phalange of digits 2, 3, 4, and 5. The thumb only has a proximal and a distal phalange. There is no middle phalange of the thumb. A lot of students confuse that. So metacarpals are here. There's 5, metacarpal 1, 2, 3, 4, 5. Before the metacarpals are the carpals. So you have 8 carpals, 5 metacarpals, and then you have your 14 phalanges. Proximal, middle, distal. The thumb only has a proximal and distal. There is no middle phalange. When you look at the femur, this is the longest bone of the body. It's part of the lower extremity. There's the head of the femur. Here's the neck. Here's the shaft. You have a greater and lesser trochanter, not to be confused with the humerus that has a greater and lesser tubercle. So the tubercles are of the humerus, the trochanters are part of the femur. And then remember, the head of the femur articulates with the acetabulum, that dish, the cavity of the pelvic bone. So this is going to project medially, which means out here, this has to be lateral. Whether it's here or here, it's still lateral. So that would be your lateral condyle. This would be the medial condyle from the anterior and the medial condyle from the posterior. If we're looking at it from the anterior, this is the intertrochanteric line, and in the back is an intertrochanteric crest. Okay. And then back here, there's a sharp ridge on the posterior called the linea aspera. The linea aspera. This is where your quadricep muscles originate. Okay, let's see, what do we have? Well, zygomatic bone? No, that's over here. Temporal bone? No, temporal is up here. Frontal bone? No, frontal bone is up here. Maxilla? Well, this is the maxilla, the upper jaw. So this would have to be your mandible. If we look underneath the skull, here's the hard palate. There's a little hole right near the incisors, so that would be the incisive fossa. A fossa is a little bit of a depression over here. Then we have the groove for the auditory tube. Here's the mastoid process. And if there's a mastoid process, there's a very, very narrow, pointy styloid process. And between the styloid process and the mastoid process, there's a hole, a foramen called the stylomastoid foramen. This is the magnum foramen. This large hole is the magnum foramen. It's actually where your brainstem descends and becomes the spinal cord. Right? Your medulla oblongata comes right through here, which is part of the brain. Occipital condyles, this is what's going to articulate with your top vertebrae, C1. That's where nodding takes place, when you just nod your head up and down. It's the articulation between the condyles, the occipital condyles and the atlas. The hypoglossal canal, that's a little hole in here for the 12th cranial nerve called the hypoglossal nerve. Mandibular fossa is where the mandible articulates with, right? You guys know it as the TMJ, the temporal mandibular joint. And then we have the opening of the carotid canal right here. So there's lots of holes in here, lots of foramen. When we look at the spine, this is the spine from the front. From the posterior, you can see the spinous processes here. This is a lateral view where you can see the cervical curve, thoracic curve, and lumbar curve. The cervical curve is called a lordosis. The thoracic curve is called a kyphosis. And the lumbar curve is called a lordosis again. So there's a cervical lordosis and a lumbar lordosis. Thoracic curve is a kyphosis, and so is the sacral curve, kyphosis. So what are they pointing to here? What are these blue structures, those transverse structures on the outside? It's not the vertebral body. That would be here in the front. These are the vertebral bodies. It's not the intervertebral discs. Those are these. It's not the facets. I'll show you what those are. It's not the spinous processes. These are the spinous processes. So that would have the transverse processes on the side. Okay, we're looking at the teeth. All right, we got to figure out what we're looking at here. Hard palate, well, that would be this. Are we looking at the maxillary teeth? Are we looking at the mandibular teeth? Well, let's see. What's highlighted here? Right, so it's got to be either mandibular or maxillary. So the mandible, that's the bottom. The maxilla is on the top with the hard palate. So that would be the maxillary teeth. Incisive would be up here. Those are your incisors. Central incisors and the lateral incisors. Let's look at the vertebrae here. This is a cervical vertebrae. How do we know? Look at the spinous process. It's bifid. So what is the transverse process? That's out here and out here. Cervical vertebrae also are the only vertebrae that have a hole in the transverse process. It's called a transverse foramen. That's where your vertebral arteries travel through that bring glucose and oxygenated blood up to the brain. This is C2, which is the axis. It's an atypical vertebrae. It doesn't have a vertebral body. It's very modified. It has an odontoid process, also known as the dens, that sticks up right here. It's the only vertebrae that has that. In order to form the spinous processes, we need to bring the lamina together. So lamina fuse to form a spinous process. So those are the lamina. The pedicles are right off the vertebral bodies. These are the pedicles here and here. Okay. From the side view, this is a thoracic vertebrae. The way we know it's a thoracic vertebrae is the spinous processes always look like a nose. Like from the side, the nose goes down, it tilts down. So the spinous process always goes down. So that's a thoracic vertebrae. Here's the vertebral body. And this is the transverse process. Off the transverse process, there's a costal facet. The costal facet, anytime you see the word costal, it's for the ribs. So the rib is going to articulate to the superior costal facet, which is right on the body, an inferior costal facet, and the transverse costal. So the ribs attach to the vertebrae in several places. Anywhere you see costal, it's going to make an attachment. Okay? So when it's on the top of the vertebral body, superior costal facet. When it's below the vertebral body, inferior costal facet. A facet is just a smooth surface. And then we have the transverse costal. Again, looking at a vertebrae, this is a bird's eye view, looking down on it, superior, looking down. This is the lateral. So from the lateral view, here's the vertebral body. What is this? Here's the vertebral body. What are these coming off the sides? Again, that would be a transverse process. So make sure you know the parts of the vertebrae, obviously. When we're looking at the lower part, this is L5, this is the sacrum, this is your pelvic girdle, this portion here is your ilium, the lower part is your ischium, top part is the pubic bone or pubis. So ischium, pubic, and ilium, those three parts fuse and they form the pelvic girdle. Okay. This is your sacroiliac joint, the joint between the sacrum and the ilium, sacroiliac joint, sacrum and coccyx. This is your pubic symphysis, that's fibrocartilage. This is your obturator foramen, largest hole, largest foramen in the body. Okay, now this is some high-tech stuff, but you may be seeing this. Some of you are in the radiological program. So when we look here, this is a lateral view of a person. These are the vertebral bodies. This is the spinous processes. This is the occiput, the base of the occiput. And here, this would be where your spinal cord is. So now we have to go, okay, what's way up at the top? Well, that's your atlas, C1. That's the anterior arch. That's the posterior arch of atlas. Remember, atlas doesn't have a spinous process. Okay, so what's below the atlas? C2, axis. And that has the dens or the odontoid process on the top. Okay, then you have C1, C2, C3, C4, C5, C6, C7. Cervical vertebrae, so these are just cervical vertebrae. Ah, there's your vertebral prominence, the most prominent spinous process. Then below that are thoracic vertebrae. Okay, just more like critical thinking type of stuff. Okay, we mentioned the different parts of the skin. So now that we mentioned the skin, let's take a look at the different layers of the epidermis. When you look at the epidermis, there are 5 stratum layers. Stratum, 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 right? Stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum germinativum. And below that, sometimes the stratum basal, sometimes they call that lowest layer, the basal layer or stratum basal. So sometimes they're interchangeable. But the germinative layer, this is all stem cells down here at the bottom. So basically the stem cells down here at the bottom are going to multiply and divide, and they push these cells upward till you get to the very, very top, which is like 25 to 30 different layers of stratum corneum. These are dead cells that slough off. It takes about 4 weeks to go from here to up here. And then they slough off. You have dead skin cells at the top. So the way you can remember these layers, again, a silly mnemonic, Cher loves getting skin Botox. Cher loves getting skin Botox. From superior to deep. Cher loves getting skin Botox. B for basal. So now when we look at these layers, we can go, okay, well, which layer do we have up here? I'm trying to see if we can see the top. This is the highlighted one. It's the only one that's different color. So towards the top, this is going to be all epithelium stratified squamous. That's going to be the stratum corneum. Then underneath the stratum corneum, if we move down, this is the stratum lucidum. And then if we go all the way down, the deepest layer, that's going to be the stratum basal. Remember, Cher loves getting skin Botox. That's the basal layer, stratum basal. Epidermis is up here. Now we have the dermis. So you have epidermis up here. Dermis has all of the hair, the blood vessels. It's going to have the erector pili. It's going to have a lot of your glands, the sweat gland. It's going to have the oil gland. Hypodermis is all the way down at the bottom. That's all fat. Epidermis is way up at here at the top. Subcutaneous layer is the same thing as the hypodermis, so they're trying to trick you there. Hypodermis and subcutaneous are the same thing. Okay, in terms of the hair follicle, here's the erector pili. Here is the exposed shaft of the hair. Here is the sebaceous gland. This is going to produce oil, and the oil moves up the hair shaft and creates this watertight seal that's also antibacterial to create this antibacterial layer and like a water resistant layer, right? The skin is not waterproof, but it is water resistant. The erector pili muscle, when that contracts, it pulls and makes the hair stand on end. We said that's what gives you the goosebumps. Here is the hair root. Here is the hair bulb. And here is your sebaceous gland or oil gland once again. When we look at the nails, we're finishing up now. When you look at the nails, this is the free edge of the nail. Here is the nail body. Here is the lunula, the white part, the empochium, also known as the cuticle, and the nail root is more posterior to that. From the side view, same structures. Here's the free edge of the nail that you can clip. Here's the nail body. Here's the lunula. Here's the empochium, or the cuticle, and then behind that you have the nail root. What's posterior to that, this is the matrix. This would be equivalent to like the stratum basalayer, where you have the stem cells that reproduce, multiply, and divide, and it's going to push the nail forward to eventually increase the free edge that you can clip. So the same structures that we see here, we can see on this view down here at the bottom. Okay, so here, this would be not the free edge, this would be the nail body. That's pretty easy. The nails are kind of neat. The nails is something that I utilize in my practice frequently. It's part of my physical exam. So when I'm meeting a patient for the first time and I shake the hand, I always turn the hand over and I look at the nails, right? I feel the strength of the hand. I look at the back of the hand for hydration. I look at the muscles of the back of the hand, but I'm looking at the nails. The nails are a window, like the eye, a window into the body where I can see the shape and coloration. It can tell me metabolically what's happening. So in this instance here, you can see where it's starting to club. This is seen with cardiovascular issues, lung cancer, heavy smokers, pulmonary issues. That's called clubbing of the nails. That's pretty severe clubbing of the nails. Usually seen with cardiovascular issues. We see it with lung disease. Sometimes we see it with inflammatory bowel disease, even with AIDS. So the looking at the nails gives us lots of information, at least to think, to critically think. These nails are not of average. They're not normal. They are abnormal. Let's investigate and look. This is normal. This is early clubbing where it starts to thicken at that cuticle. Here it becomes even thicker. This is called clubbing of the nails. When the nails go the other way, it's called spooning of the nails. We see that with fungal infections and severe diabetics. Here, this should be pink. When it's white, we're thinking maybe it's anemia, right? Lack of oxygen, lack of iron, B12, could be an iron deficiency anemia or B12, could be heart failure, malnutrition, liver disease, but usually in anemia. I've seen this on several patients over the years. This is a melanoma. This is a type of skin cancer, subungual melanoma. Here you can see these striations. This could be with diabetes. It could be with thyroid issues. I've seen it. B vitamin deficiencies, an endocrine disorder called Addison's disease. We know that that's an issue with cortisol. So we'll take a look at that later on in the term. So nails, very important. It at least allows us to investigate. Okay, let me stop the recording here. Stop the sharing.